Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I'll be doing the quick revision of the entire cardiology, mainly taking into consideration of the previous year questions which were being asked in the UPSC exam, right? So the first question goes like this. We have a 60-year-old man comes to the emergency department with a history of chest pain which is acute in onset. The ECG shows SC segment depression and T wave inversion. The cardiac biomarkers in the blood, they are not elevated. What will be the appropriate management in this patient? The options are oxygen, aspirin, ticagrelor and metoprolol. Second option, oxygen, sublingual nitrate, antiplatelets and streptokinase. Then antiplatelets, low molecular weight heparin subcutaneous. Then fourth option is oxygen plus sublingual nitrate and the digoxin. So what is this clinical scenario suggestive of? This clinical scenario, it is suggestive of the coronary artery disease, right? And this particular coronary artery disease, like how do we classify that into? We classify that into the individuals with ischemia, right? Where there is only decreased blood supply. And the second group of individuals are the infarction, where there is the death of the myocardium. And you have to understand that in both of these scenarios, you will have the presence of chest pain, that is angina. Then how is that you will be able to differentiate both of these patients is by the cardiac biomarkers. So if you take the cardiac biomarkers in case of the infarction, they are positive, whereas the cardiac biomarkers in case of ischemia, they are negative. So these are the two important points. This is a very important difference. How will you differentiate infarction from the ischemia? So what is the spectrum under your ischemia is? Under the ischemia, like we have the stable angina, then we have the Prinzmetal angina, then we have the unstable angina. Then infarction, based on the ECG, we classify that into the non-ST elevation MI and as well as the ST elevation MI. So this is how we categorize the patients with the coronary artery disease. Now you take the last three. So last three, right, last three, that is unstable angina, NSTEMI and as well as STEMI, they come under the category of the acute coronary syndrome. So acute coronary syndrome is that where these patients, they require, or these spectrum of the patients require the emergency treatment. What is that emergency treatment that you need to give in these patients is, right? So these patients will immediately require the first line treatment in these patients with the acute coronary syndrome is the aspirin. And all these patients with acute coronary syndrome, they will be requiring the dual antiplatelet drug. So they will be also requiring the clopidogrel. So these two are the antiplatelets. It will prevent further clot formation. And because there is ischemia and as well as infarction, the oxygen therapy is very, very important. And then followed by that, the nitroglycerin, that is NTG. Now, in this acute coronary syndrome, how is that you will be able to differentiate unstable angina, NSTEMI and as well as the STEMI? In both of these category of patients, that is unstable angina and as well as the NSTEMI, they will have the ST segment depression within the ECG. But in NSTEMI, the cardiac biomarkers, they are positive. Whereas in unstable angina, the cardiac biomarkers, they are negative. Whereas in case of STEMI, you will notice that there is the ST segment elevation. And this ST segment elevation, it should be more than 2 mm in the chest leads, that is from V1 to V6. And it should be more than 1 mm in the limb leads. And what are these limb leads? That is L1, L2 and as well as L3. And even in the augmented leads, that is AVR, AVL and as well as AVF, you have the you should have the ST segment elevation of more than 1 mm. So this is how you will be able to differentiate the spectrum of the acute coronary syndrome also. Now this ST segment elevation also, if you observe, if the ST segment elevation is there in V1 to V4, this we call it as the anterior wall MI. If the ST segment elevation is there in 2-3 AVF, then we call this as the inferior wall MI. And if the ST segment elevation, if it is present in 1 AVL, V5 and as well as V6, this is suggestive of the lateral wall MI. right? This is suggestive of lateral wall MI. So this is how we categorize the patients with the ST elevation MI. Depending upon the ECG changes, we will be able to make out anterior wall, lateral wall, and as well as the inferior wall MI as well. Now we will just go back to our question, right? So in the question, what do you think is the correct answer? The correct answer is the oxygen therapy, aspirin, ticagrelor, and as well as the metoprolol. So what is ticagrelor? Ticagrelor, it is also like one of the colleague of the clopidogrel. It is also an antiplatelet drug, right? And why is that we need to give beta blocker, which is the one which will reduce the heart rate, is because in patients with the myocardial ischemia or in patients with the myocardial infarction, we want to reduce the heart rate in order to reduce the myocardial oxygen demand. That is the reason why we need to give beta blocker. So the best answer in this question is the first option. Then what about the other options? So first of all, like what is the diagnosis? The patient is having the ST segment depression and the T wave is inverted and the cardiac biomarkers are not elevated. So this is suggestive of the unstable angina. So in unstable angina, it comes under your acute coronary syndrome, which requires oxygen therapy, DAPT, and as well as the beta blockers have to be supplemented, right? And what about the second option? See, in second option, you have streptokinase, which is a thrombolytic therapy. Please remember, in case of unstable angina or NSTEMI, we don't give thrombolytic therapy. What is that we give in case of the unstable angina and as well as the NSTEMI is, we give anticoagulant, right? So what will be that anticoagulant is? The anticoagulant, either it is the unfractionated heparin or low molecular weight heparin, or you can also give even the fondaparinux as well, right? So, but thrombolysis, it is avoided or contraindicated in case of unstable angina and as well as STEMI. Then in which group of individuals you do thrombolysis? That is in case of STEMI, these patients, they will be requiring thrombolysis with either streptokinase or urokinase or retiplase or altiplase and even tenecteplase, okay? So these are the various thrombolytic agents which are used in the treatment of STEMI, that is ST elevation MI, but not in case of NSTEMI or the unstable angina. So your second option is ruled out. Then you take the third option, antiplatelets, low molecular weight heparin. Actually, your third option is correct, but the very important add-on thing which is required is the oxygen therapy. Oxygen therapy is like mandatory for a patient who is coming with the coronary artery disease. So that is the reason why your option 3 is wrong. Otherwise, the treatment, whatever the option 3 contain antiplatelets and anticoagulant, that is correct, but it is inadequate treatment without oxygen therapy, right? Next, now you take the fourth option. We give oxygen, yes. We give sublingual nitrate, yes. But digoxin, there is no role of digoxin. What exactly is your digoxin? It is the one which will increase the cardiac contractility, right? And it will act as the speed breaker at the level of the AV node. In that way, it is used in the treatment of atrial fibrillation, right? But it will increase the cardiac contractility. In patients with ischemic heart disease, we don't want increase in cardiac contractility because it will further increase the myocardial oxygen demand. So that is the reason why we don't give digoxin in patients with the MI or in patients with the coronary artery disease. So that is the reason why even your fourth option is also incorrect. So now, if you take the unstable angina and as well as the NSTEMI, let me just give you a little more discussion about this unstable angina and as well as the NSTEMI. Unstable angina and NSTEMI, in both of them, the treatment is same, right? The treatment is same. I'll discuss what exactly is the treatment, right? And if you take the angina onset, the onset of the angina is that even at rest also these individuals will develop angina. Whereas in case of the stable angina, in stable angina, these patients, they will develop angina on exertion and the chest pain will be less than 10 to 15 minutes in case of the stable angina. Whereas in case of NSTEMI, the duration of the chest pain will be more than 15 minutes also. And even the chest pain can be there at rest, right? When you compare that with stable angina, the chest pain will be there only on exertion. Upon taking rest, the chest pain, right? Only upon exertion. Upon taking rest, the pain will subside in case of stable angina. And whereas you take ECG in unstable angina as well as NSTEMI, in both of them, you have ST segment depression and the T wave inversion. And what about the cardiac biomarkers? So the cardiac biomarkers that will be elevated are the troponin, which I'll be discussing subsequently in detail, and as well as the 𝐶KMB. So the troponin and as well as the 𝐶KMB, they are positive in case of the non-ST elevation MI, whereas they are negative in case of the unstable angina. Then what do you think is the first line treatment in patients with acute coronary syndrome? As just now I was discussing, the aspirin is the first line treatment, but you need to add the DAPT, that is dual antiplatelet therapy. So in the dual antiplatelet therapy, either you can give the clopidogrel, right, or the ticagrelor can be given, right, clopidogrel or ticagrelor. And oxygen therapy is very much required in these patients with ischemia or infarction. An anti-anginal drug, that is, we give nitrates. The advantage of nitrates is that it will not only cause coronary artery vasodilatation, it will also reduce the preload and as well as the afterload. And another important anti-anginal drug that can be given is the morphine. And anticoagulant, yes, this is the way by which you will be doing the revascularization in case of NSTEMI and as well as the unstable angina. As I was telling, the low molecular weight heparin or the fondaparinux, right, or the unfractionated heparin can be given. Either of these can be given. Whereas thrombolysis, no, thrombolysis should not be done. And once the individual is stabilized, you need to do coronary angiogram. And in the coronary angiogram, if the stenosis of the coronary artery, right, if the stenosis of the coronary artery, if it is more than 70%, then you need to plan for the PCI, that is percutaneous coronary intervention has to be done. So this is about the unstable angina and as well as the NSTEMI in total, right? And I'll be discussing in detail about the PCI subsequently, because in PCI, like, we use the stents, and the stents that we use in these individuals will be the drug-eluting stents, right? So drug-eluting stents are those which includes the sirolimus, right, which includes the sirolimus or the everolimus, right? So sirolimus or everolimus coated stents is what we use, okay? So they prevent the restenosis or they prevent the reatherosclerosis. That is the advantage of the drug-eluting stents, right? Now, following, that was the first question. Coming on to the next question. Which of the following is not the differential diagnosis of the ST segment elevation in the ECG? Acute pericarditis, trauma to the ventricles, hypothermia, and then hypocalcemia. Now you take this ST segment elevation, it is not just present in case of MI. There are multiple other conditions where you have the presence of ST segment elevation. That includes acute pericarditis, trauma to the ventricles, and as well as the hypothermia. But in hypocalcemia, you don't have the ST segment elevation. And in fact, what is the abnormality that you will have in case of the hypocalcemia? In hypocalcemia, you will have a long QT interval, right? Long QT interval. See, the normal QT interval is around 360 to 460 milliseconds. But in these individuals, the QT interval will be more than 460 milliseconds. And those individuals who are having long QT interval, they can predispose to the development of the polymorphic ventricular tachycardia, which is nothing but 𝗏𝐳_D. That is the complication associated with this long QT intervals. And exactly you take in case of the hypercalcemia. In hypercalcemia, the QT interval will be shortened. So these patients, they'll have the short QT interval. Whereas the remaining three options like acute pericarditis, trauma to the ventricles, and hypothermia, they will have ST segment elevation. Now, let me tell you all the conditions where you have the ST segment elevation. I'll tell you that in a form of a mnemonic. And that particular mnemonic is elevation AB. So what is this elevation AB? The word E stands for the electrolyte abnormality. And what is that electrolyte abnormality? That is the hyperkalemia. L stands for left bundle branch block, right? And the word E, it stands for early repolarization syndrome. I'll be showing you all these ECGs, early repolarization syndrome or early repolarization variant, okay? Then elevation VA, that is ventricular aneurysm. So in ventricular aneurysm, which occurs secondary to the anterior wall MI, you will have tomb-shaped ST segment elevation, which I'll be showing you. And T stands for trauma to the ventricles. Like while doing the pericardiocentesis, like if there is any trauma to the ventricle, then you will observe that there is ST segment elevation. And the word I, it stands for ischemic injury, which is nothing but the infarction, right? Ischemic injury, which is nothing but infarction, okay? And usually in case of the stable angina and as well as unstable angina, you will have ST segment depression. But the only form of angina where you have ST segment elevation, that will be the Prinzmetal angina, right, which is also called the variant angina. So Prinzmetal angina or variant angina, you have the presence of the ST segment elevation. And the word O, it stands for the Osborn wave. So where do you see this Osborn wave? You come across this Osborn wave in patients with the hypothermia, right? In patients with hypothermia, you have the presence of the Osborn wave. So in hypothermia, you will also have the ST segment elevation. I'll show you this Osborn wave subsequently in the next questions. And the word N, it stands for non-occlusive vasospasm, which is nothing but your Prinzmetal angina or variant angina. So the Prinzmetal angina or variant angina is that where these individuals, they will have transient coronary vasospasm. Only during the time of coronary vasospasm, you will have ST segment elevation. Then which particular coronary artery most commonly undergo transient coronary vasospasm is the right coronary artery, right? And this is more common, the Prinzmetal angina is more common in females, and that too in individuals with Raynaud's phenomena, right? And in those individuals who are consuming this ergot alkaloids, in them also the Prinzmetal angina or variant angina is very common. And during the episode of the chest pain, if you do an ECG, you will notice that there is ST segment elevation. Then what is the drug of choice in patients with the Prinzmetal angina? The drug of choice in case of the Prinzmetal angina or the variant angina is you need to give the nitrates, right? You need to give nitrates. And the alternative drugs will be the calcium channel blockers. Alternative drugs will be calcium channel blockers. Okay. And then what are that AB? AB stands for acute pericarditis and B stands for the Brugada syndrome. So these are all the conditions where you have the presence of ST segment elevation apart from STEMI. Now let me show you all these ECGs. So this is the ECG of the hyperkalemia. So in hyperkalemia, along with ST segment elevation, you also have the presence of the tall T wave, tall tented T wave. And even if you observe the QRS complex, you have a wide QRS complex that you will be observing, right? And at one point of time, the P wave, right, it slowly, you will have what is called sine wave pattern, right? Okay, so this will be the ECG of your hyperkalemia. And what is the drug of choice for hyperkalemia is the calcium gluconate has to be given. And how is that? This calcium gluconate will not reduce the potassium levels. Calcium gluconate will only sensitize the cardiac membrane and prevent the development of the arrhythmias. And the drugs which will reduce the potassium are, you need to give insulin plus dextrose, you need to give the salbutamol nebulization, you need to give the furosemide, which will cause the flushing out of the potassium, right? And then you have a potassium binding agents, that is sodium polystyrene sulfonate. And if the individual is refractory to medical management, then you need to do hemodialysis to reduce the potassium levels, right? So this is the ECG of hyperkalemia. Now this is the ECG of the LBBB. So in patients with LBBB, you will have the wide QRS complexes, right? You will have wide QRS complexes, and then followed by that, like not same exactly, but W-shaped S wave in V1 and M-shaped R wave in case of V6. So this will be like the ECG in patients with the left bundle branch block, where you will have the presence of ST segment elevation. And what is the conditions? What are the conditions where you can have the development of LBBB is in patients with the anterior wall MI. You will also have that in patients with the aortic stenosis. These are the conditions where you can have the development of the left bundle branch block, where you have the presence of ST segment elevation, right? And this is the ECG of the acute pericarditis, where you have the presence of global ST segment elevation. That means the ST segment elevation, and that too a concave ST segment elevation will be there. And this concave ST segment elevation will be observed in more or less all the leads, right? In more or less all the leads, okay? And but only thing is, in AVR, you will notice that there is the ST segment depression. So you can just observe here, this is AVR, where you have the presence of the ST segment depression. So along with ST segment elevation, and that too concave ST segment elevation, what is the other ECG change that you will have in these patients is the PR segment depression will be there, okay? So you can observe that this is the PR segment depression, right? So this is the PR segment depression, that is what you will have in patients with acute pericarditis. And we have a case of acute pericarditis subsequently, I'll be discussing that. Now, so this is what is your tomb-shaped ST segment elevation. Now, where is that you will have the tomb-shaped ST segment elevation is? That is in patients with the ventricular aneurysm. So, ventricular aneurysm, it is one of the complications associated with the anterior wall MI, right? And the next important condition where you will have ST segment elevation is in patients with STEMI, right? So, you are having ST segment elevation in V1 to V4. Along with that, you are also having ST segment elevation in 1 AVL V5 V6. So, this ECG, it is suggestive of the anterolateral MI, right? This ECG, it is suggestive of the anterolateral MI, right? Now, what do you think is the best treatment in this patient, or the best method of revascularization in patients with the ST elevation MI is the PCI, percutaneous coronary intervention, and followed by that, the next best would be the thrombolytic therapy. And thrombolytic therapy also, I have said there are 5 thrombolytic agents: streptokinase, urokinase, alteplase, reteplase, tenecteplase, and out of which the best thrombolytic agent will be tenecteplase, which will cause maximum revascularization then compared to that of the other thrombolytic agents, right? Then yes, you see this particular ECG here. This ECG, you are having the curved ST segment elevation, right? This ECG, you are having curved ST segment elevation mainly in lead V1 and as well as V2. This curved ST segment elevation in V1 and V2, it is very much suggestive of the Brugada syndrome. And this Brugada syndrome, it is a sodium channelopathy. These patients, they are at increased risk of VT and as well as VF causing sudden cardiac death. So Brugada syndrome is one of the cause for the sudden cardiac death where you have the presence of the sodium channelopathy. So these are all the conditions where you have the presence of the ST segment elevation ST segment elevation within the ECG. So what is the mnemonic? Elevation AB, that is the mnemonic, right? Then, so the next question is, which one of the following is a non-shockable rhythm in respect to the use of the automatic external defibrillator? The options are monomorphic ventricular tachycardia, polymorphic ventricular tachycardia, ventricular fibrillation, and pulseless electrical activity. So, non-shockable rhythm, right? What is the example of the non-shockable rhythm? The example of the non-shockable rhythm is the pulseless electrical activity is a non-shockable rhythm, right? Now, let me explain you which are your shockable rhythms and which are the non-shockable rhythms. The remaining all in the options, they are shockable rhythms, right? So, the various examples of the shockable rhythms are ventricular tachycardia, right? And as well as the ventricular fibrillation. So when is that ventricular tachycardia you will do, you will give a DC shock is if the individual is hemodynamically unstable, right? So if the individual is hemodynamically unstable, that is when we give the shock, okay? So it is not hemodynamically stable VT you give a shock. It is in case of the hemodynamically unstable. What do you mean by the word hemodynamically unstable? Where the patient should be having the hypotension, right? Where the patient should be having dyspnea, where respiratory rate is very much elevated, where the saturation of the individual drop down. So in case of hemodynamically unstable VT, like we give a shock. So the type of shock what we give is synchronized DC shock, that is direct cardioversion. And what is the strength you give? The strength what we give here is around 200 to 360 joules is what we give, right? Then you take in case of the VF, that is ventricular fibrillation. In case of the ventricular fibrillation, these patients, they are always hemodynamically unstable. So definitely you need to give the shock. It's a shockable rhythm. And the strength what we give is around 300 to 400 joules is what we give in case of the ventricular fibrillation. And the other conditions where we give the shock is, or shockable rhythms are atrial fibrillation with hemodynamically unstable, right? Atrial fibrillation, hemodynamically unstable. What is the strength we give? That is 200 joules. Synchronized cardioversion is what we do. And next is the atrial flutter. Atrial flutter with hemodynamically unstable. And what is the strength of the shock we give here is the 50 joules. Okay, so these are all the shockable rhythms, and in all of these conditions, okay, right, we give shock. But please remember, in case of the VT we give synchronized shock, but whereas in case of VF it is asynchronous shock, right? It is asynchronous shock in case of the ventricular fibrillation. All right, whereas in AF and as well as atrial flutter, again it is the synchronous shock, right? And one more conditions where we give the asynchronous shock is in case of the pulseless VT. In pulseless VT also we give the asynchronous shock. Otherwise in the VT with pulse, whereas hemodynamically unstable, we give the synchronized DC shock. And what are the examples of the non-shockable rhythms? The examples of non-shockable rhythms are, right, that is PEA, that is pulseless electrical activity, right? So here in this individual, the heart is having the electrical activity, but it is not effective in producing the pulse. Then how is that you will be able to make out that there is electrical activity? By observing the pulse oximeter, right? Or by observing the cardiac monitor, we will be able to make out that there is a pulse or electrical activity in the individual, right? And one more condition which is a non-shockable rhythm is the asystole. Okay, so asystole, it is like complete flat line. So complete flat line, this represents that there is total absence of electrical activity in the heart. So in asystole, it is a non-shockable rhythm, right? So what are the conditions, right, where you give the synchronized DC shock? That is in case of VT, in case of the atrial fibrillation, in case of the atrial flutter, right, in case of the supraventricular tachycardia. Always remember, in order to give DC shock, the individual should be hemodynamically unstable, right? So hemodynamically stable, we don't give the DC shock at all, okay? And asynchronous DC shock, you give that in case of the ventricular fibrillation and as well as the pulseless VT, right? So this is about the question related to DC shock. Next question, if you observe, 50-year-old man reports to the emergency with breathlessness, palpitations and acute chest pain. On auscultation, there is a systolic murmur at the apex and ECG shows the ST segment elevation in the anterior leads. Which one of the following would be the next choice of the investigation? The options are the cardiac biomarker, that is troponin, and echocardiography, TMT, 24-hour Holter monitoring investigation, right? So here the best answer is the echocardiography. Let me explain you why. So the patient is having the ST segment elevation in the anterior leads. So what do you think is the correct answer here? I mean, the diagnosis here is the anterior wall MI. And in patients with anterior wall MI, the vessel that is being blocked is the left anterior descending artery is being blocked, right? So when the left anterior descending artery is being blocked, the anterior wall, it gets infarcted. Within the anterior wall, you have the presence of the papillary muscle, right? You have the presence of the papillary muscle. Now this particular papillary muscle, it can rupture, right? So this papillary muscle, it can rupture. So once the papillary muscle ruptures, then the strength within the chordae tendineae or tension within the chordae tendineae is being lost, and the individual will develop mitral valve prolapse, causing the mitral regurgitation. So basically this is one of the complications of the MI, right? Now, what is the systolic murmur due to? The systolic murmur in the apex, it is mainly because of the mitral regurgitation. So, now if you observe the complications of myocardial infarction, the complications of the myocardial infarction, it includes the following, right? Number one will be the structural complications and electrical complications. Then we have the late complications in the myocardial infarction. Structural complications include MR, that is very common in case of the anterior wall MI and as well as the inferior wall MI. Even in the inferior wall MI also, the story is the same. One of the papillary muscle is present in the inferior wall. So once the inferior wall is infarcted, the papillary muscle over the inferior wall can get ruptured, causing MR. Then VSD. VSD is very common in the anterior wall MI, because the interventricular septum, that is anterior 2/3, it is supplied by the left anterior descending artery. In anterior wall MI also, the left anterior descending artery is being blocked, right? So once the left anterior descending artery is being blocked, the blood supply to the anterior 2/3 of the interventricular septum will be lost, and that anterior 2/3 of interventricular septum which is infarcted can get ruptured, resulting in ventricular septal defect. And the another important structural complication will be the complete cardiac rupture, where the individual will have a cardiovascular collapse and as well as death. So these are all the structural complications, and that too acute, right? Acute structural complications. Whereas the electrical complications that you will observe is the bradyarrhythmias, or there can be even the complete heart block. This complete heart block or bradyarrhythmias are very common in case of the inferior wall MI and as well as the right ventricular MI, right? Then next important electrical complication would be the tachyarrhythmias. The tachyarrhythmias include the VT or the ventricular fibrillation. Once this patient develops VT or VF, these patients will be requiring DC cardioversion. And once these patients develop complete heart block, these patients should be placed on the TPA, that is temporary pacemaker insertion, right? Then what is the late complication in case of MI is, the late complication will be the Dressler syndrome. Now what is Dressler syndrome? Dressler syndrome, it is a post myocardial infarction pericarditis, right? Post myocardial infarction pericarditis. So this Dressler syndrome will develop after weeks to months after the development of MI, right? It will develop weeks to months after the development of MI, and it is post myocardial infarction pericarditis. It's an inflammatory pathology. So the ESR is elevated in these patients, and what is the treatment that you need to give is, you need to give increase in the dose of the aspirin, because it is an anti-inflammatory drug, and if the patient does not respond only to the aspirin, then you need to give the colchicine or corticosteroids can be given. So this is about the complications related to the myocardial infarction. Then you take the other options. So what is the answer here? So how is that you will be able to make up this MR? That is by your mitral regurgitation, that is by your two-dimensional echocardiography. Then you take the other options like the cardiac troponin and as well as the treadmill test. So right, so if you take the discussion related to the treadmill test, this is nothing but the stress test. In which group of individuals you require treadmill test for the diagnosis of the underlying coronary artery disease is mainly in patients with the stable angina, right? They will be requiring the stress test to diagnose the underlying coronary artery disease. And whenever the individual is doing the treadmill test, the protocol that we follow is the Bruce protocol for the diagnosis of the underlying ischemic heart disease. So what should be the diagnosis is, there should be new onset the ST segment depression, okay? So, and this ST segment depression, it should be, right, this should be downsloping ST segment depression, and this downsloping ST segment depression, it should be more than 0.1 millivolt, right? It should be more than 0.1 millivolt below the baseline, okay? And this ST segment depression of more than 0.1 millivolt below the baseline, this should be there, right? This should be there for more than 80 milliseconds, right? This should be there for more than 80 milliseconds, okay? Right? Either it should be a downsloping ST segment depression, or the ST segment, it should become flat, okay? It should become flat and down, right? And how much? It should be more than 0.1 millivolt below the baseline. So this, we call it as the treadmill test to be positive, and it is very much suggestive of the underlying ischemic heart disease. And you need to be aware of the contraindications of the treadmill test. The absolute contraindications will be, the individual had an acute myocardial infarction in the past 2 days, right? Treadmill test should not be done. And if the patient is having uncontrolled cardiac arrhythmias, that is VT or VF, right? Treadmill test should be contraindicated, right? And if the patient is having symptomatic severe aortic stenosis, right? Symptomatic severe aortic stenosis, it is also an absolute contraindication. And next is the aortic dissection, right? Next is the aortic dissection. this is also an absolute contraindication. And next is the development of or presence of pulmonary embolism, massive pulmonary embolism. This is also an absolute contraindication for the stress test or the treadmill test. Okay. Now, after having discussed about the treadmill test, the another important option was the cardiac biomarkers. Please remember, the first cardiac biomarker to rise after myocardial infarction, right? After myocardial infarction, the first cardiac biomarker to rise is heart fatty acid binding protein, right? Heart fatty acid binding protein, and followed by that the myoglobin, right? But these two are the non-specific, right? So the markers which we take into consideration are mainly the troponin T or I. The next one is the 𝐶KMB, right? The next one is the 𝐶KMB, right? And how is that? You will be able to assess the reinfarction. Okay, so the reinfarction, it is by, or it is diagnosed by 20% increase in the cardiac biomarkers, right? 20% increase in the troponin over the baseline troponin T value. Okay, see, the normal troponin T value, it is like less than 0.04, right? And now suppose if the patient with MI has come and that particular patient troponin T, let us just assume it is 10. And how is that you should be able to assess like the reinfarction, that is from the baseline value 10, it should increase like more than 20% of the 10. So the value should be like more than 12. Then we consider that it is a reinfarction. Okay, so that is about the cardiac biomarkers. And this particular cardiac biomarkers, both of them, the troponin and as well as the 𝐶KMB, both of them, they appear in the blood after 2 to 4 hours. And the troponins, they peak within 1 to 2 days. Whereas 𝐶KMB, it will reach the peak value within 1 day. And for how long this will remain get elevated? The troponin will remain get elevated for almost 10 to 14 days. Right? Whereas the 𝐶KMB, it remains elevated for almost 3 days. Okay. So 4th day morning, right? 4th day morning, the 𝐶KMB value will return back to normal. 𝐶KMB value will return back to normal. And if you take these troponins, this particular troponins, they are elevated not only in patients with MI. There are many other clinical conditions where the troponin values are elevated. That includes the myocardial infarction, that includes the congestive heart failure, that includes the atrial fibrillation, that includes acute pulmonary embolism. It is also elevated in chronic renal failure. It is also elevated in patients with the myocarditis. Okay, and even in case of sepsis, right? Even in case of sepsis, the values are being elevated. Which one? The troponin values are being elevated. So that is about the question on the complications related to the myocardial infarction. So in this question, like what you need to do, echocardiography has to be done. So this is the 4th question. Then, so coming on to the 5th question, which of the following electrocardiographic findings are manifestations of the digitalis intoxication? Ventricular bigeminy, ventricular tachycardia, atrial flutter, atrial tachycardia with variable block, right? So the digitalis, it is associated with almost all the forms of arrhythmias, but the arrhythmias that is not observed with the digitalis intoxication is the atrial flutter, right? And digitalis intoxication is associated with ventricular bigeminy, associated with ventricular tachycardia, and atrial tachycardia with variable AV block. So the answer will be 2. Now let me discuss about the digitalis intoxication. So in case of the digitalis intoxication, if the question is asked what is the most common arrhythmia in case of digitalis intoxication, is the ventricular bigeminy, right? Ventricular bigeminy. So that is the reason why in patients with digoxin toxicity, what is the characteristic pulse? The characteristic pulse will be pulsus bigeminus. right, pulses bigeminous, that is the characteristic pulse in case of the ventricular bigeminy, right? Now, let me discuss in detail about the digoxin-induced arrhythmias. But before that, let me explain you that digoxin toxicity, it is not associated with certain arrhythmias. What are those arrhythmias which are not associated with digoxin toxicity? That includes the atrial fibrillation, right? That includes the atrial fibrillation, and the other arrhythmias are the atrial flutter, right? And it is also not associated with second degree AV block, Mobitz type 2. Okay, so it is not associated with Mobitz type 2 AV block. These are the arrhythmias that are not observed in case of the digoxin toxicity. Whereas, if you take in case of the digoxin induced arrhythmias, it is digoxin toxicity, it is associated with the tachyarrhythmias, right? And it is also associated with the bradyarrhythmias, right? Now, what are the tachyarrhythmias which are associated with the digoxin toxicity? The tachyarrhythmias which are associated with the digoxin toxicity, it includes both the atrial arrhythmias and as well as the ventricular arrhythmias, right? That is ventricular tachyarrhythmias. The atrial arrhythmias, that includes the atrial tachycardia, right? Atrial tachycardia with variable AV block. But this particular digoxin toxicity, as I have said you just now, it is not associated with atrial fibrillation, not associated with the atrial flutter. Why? Because digoxin, it is having AV nodal blocking activity, right? Because digoxin is having AV nodal blocking activity, the atrial fibrillation and as well as in atrial flutter, we give digoxin as a treatment for reducing the ventricular rate, okay? And because of this AV blocking activity, there can be atrial tachycardia with variable AV block. And the ventricular arrhythmias that are associated are the ventricular tachycardia and as well as the ventricular fibrillation. And in case of digoxin-induced ventricular tachycardia, the drug of choice will be lignocaine. So lignocaine, it is considered as the drug of choice for digoxin-induced ventricular tachycardia, right? Now, coming to the bradyarrhythmias. The bradyarrhythmias that are associated with the digoxin toxicity, it includes the AV block. Okay, so there can be even development of third degree AV block as well, which is nothing but the complete heart block. Now the question comes, and it is also associated with the second degree AV block, right? It is also associated with second degree AV block, that is Mobitz type 1, which is also called as the Wenckebach's phenomena, which is also called Wenckebach's phenomena, right? And one of the very important point that you need to know and understand here is that it is not associated with Mobitz type 2. Why? Because in order to develop the Mobitz type 2, where should be the block, right? Where should be the pathology? In Mobitz type 2, the pathology will be exactly below the AV node, that is in the bundle of His, right? And the digoxin will not cause the blockade of the bundle of His. That is the reason why digoxin toxicity is not associated with Mobitz type 2 second degree AV block. And digoxin toxicity, it is associated with ventricular arrhythmias because it will increase the calcium levels within the sarcoplasmic reticulum, right? So thereby it will increase the contractility, causing the ventricular tachycardia and as well as the ventricular fibrillation. Okay, so these are all the examples of the digoxin induced arrhythmias, right? And the atrial arrhythmias, if you observe, one I've said you, that is atrial tachycardia. Apart from atrial tachycardia, there can be even the sinus bradycardia, right? There can be sinus bradycardia, there can be sinus tachycardia, right? There can be sinus block and arrest, right? There can be sinus block and arrest, right? So these are all the the atrial arrhythmias which are associated with the digoxin toxicity. Okay, right? Now, what are the other features that you are having with chronic digitalis intoxication? The chronic digitalis intoxication, it is associated with, first and foremost, very important feature is these patients, they will have nausea and as well as the vomiting, right? So this will be the earliest manifestation in case of the digoxin toxicity. And digoxin toxicity is also associated with weight loss. And the vision, if you observe, that is called as the yellow vision, right? And next important is this chronic digitalis intoxication, it is associated with the development of the delirium, right? And these patients, they will also have gynecomastia, right? They are associated with the development of the gynecomastia. And there are multiple other drugs which are associated with the development of gynecomastia. That includes spironolactone, that includes digoxin, that includes the isoniazid, right? That includes the estrogen supplementation, that includes the cimetidine. These are all the other drugs which are associated with the development of the tender gynecomastia. And the next important point here is they will have cachexia, which is nothing but the weakness. Okay, so these are all the features which are associated with chronic digitalis intoxication. Then how is that you will do the management of the digitalis overdose? First and foremost, you stop the drug or you withdraw the drug, right? And you need to monitor the potassium. Okay, and if there is hypokalemia, you need to supplement the potassium. Otherwise, the tachyarrhythmias, they get precipitated, right? Now, these patients are having ventricular tachycardia. So for digoxin-induced ventricular arrhythmias, what is the drug of choice we have discussed? That is, lidocaine is considered as the drug of choice. Okay, and if the patient is having the development of the AV block, that is complete heart block, then these patients, they will be requiring the cardiac pacemaker, right? These patients, they will be requiring the cardiac pacemaker. And if there is development of ventricular fibrillation is a type of arrhythmia which is associated with hemodynamic instability. And if there is development of ventricular fibrillation, they will be requiring the electrical cardioversion, right? So they will be requiring the electrical cardioversion. Okay, so this will be the treatment if the patient develops ventricular fibrillation. And what exactly is the antidote for the digitalis induced toxicity? So we give digitalis antibodies, right? Digitalis antibodies, right? Which is nothing but the FAB fragments, right? Which is nothing but FAB fragments, digoxin induced Fab. So this digitalis antibody, it is potentially life-saving, right? It is potentially life-saving in severe intoxication, right? So this is about the digitalis overdose and digoxin toxicity, which is associated with multiple arrhythmias except atrial fibrillation, atrial flutter, and Mobitz type 2 AV block, that is second degree AV block, right? Now, we'll move on to the next question. We have a 35-year-old patient presents in the emergency with sudden onset palpitation. His heart rate is 150 per minute and it gets reverted after carotid sinus massage. What do you think is the most probable diagnosis? Paroxysmal supraventricular tachycardia, ventricular tachycardia, ventricular fibrillation, atrial flutter with block. So the patient is having the palpitations and heart rate of 150 and it is getting reverted with carotid sinus massage. That is very much suggestive of the paroxysmal supraventricular tachycardia. Now, what exactly the carotid massage will do? It will stimulate the vagus nerve, right? It is a vagal maneuver which will cause the AV nodal block, and that will suppress the development or progression of the paroxysmal supraventricular tachycardia. Let me show you the ECG of the paroxysmal supraventricular tachycardia. So, in case of the PSVT, right, you take the P wave. So the P wave, it is almost absent, or the P wave, it gets merged with the QRS complex, right? It gets merged with the QRS complex, right? And that because of paroxysmal supraventricular tachycardia, the T wave, it is inverted, right? The T wave, it is inverted. So this will be the class, and the QRS complexes, if you see, they are narrow QRS complexes, right? The QRS complexes are the narrow QRS complexes. That is what you will observe in case of the paroxysmal supraventricular tachycardia. Now, how do you treat these patients with paroxysmal supraventricular tachycardia? Now, what is the first line treatment that you will give in case of the PSVT is, first line treatment is the stimulation of the vagus, okay? So you need to increase the vagal tone, right? So you need to increase the vagal tone, okay? Now, what are the various ways by which you can activate the vagus or increase the vagal tone, okay? Number one is the carotid sinus massage, okay? So while doing the carotid sinus massage, like how is that you should be doing this carotid sinus massage? Carotid sinus massage, where you need to palpate one carotid artery at a time and then you need to rub over the carotid, right? So which is present medial to the sternocleidomastoid muscle. But please remember, if there is presence of a carotid bruit, right, before doing the carotid sinus massage, you need to auscultate over the carotid, because over the carotid, if there is presence of a bruit, that means there is atherosclerosis, okay? So if there is a carotid bruit, then carotid sinus massage, it should be avoided, right? And you need to apply a firm but gentle pressure, and massage is applied first over the right carotid sinus. For how long you need to apply the massage? You need to apply the massage for nearly around 10 to 20 seconds, right? And if over the right carotid sinus, after applying the massage for 10 to 20 seconds, if it is unsuccessful, then you need to apply the massage over the left carotid sinus. But please remember, pressure should not be exerted on both the sides at the same time. So this is one form of the activation of the vagus. And the next important is like the modified Valsalva maneuver, right? Modified Valsalva maneuver. So modified Valsalva is that here this is also a maneuver which will cause the activation of the vagus, right? Now how is it performed? It is performed with patient in semi-recumbent position, okay? So what should be the angle? The angle, it should be 45 degrees, right? And you need to exert the pressure. And how much is the pressure that you need to exert? You need to exert the pressure of around 40 millimeters of mercury. Now, by exerting the pressure, right, what will happen to the intrathoracic pressure is the intrathoracic pressure will be increased, okay? And you need to do that with the help of a 10 ml syringe. And for how long this pressure has to be exerted is, you need to exert the pressure for nearly around 15 seconds, okay? So now after doing this, right, so after doing this particular application of the pressure into the 10 ml syringe for 15 seconds, and how much pressure? Like the manometer has to show the 40 millimeters of mercury reading, right? Now, after that, what is that you need to do is move the patient into supine position immediately, right? Move the patient into the supine position immediately, and then you need to do a passive leg raising, right? You need to do a passive leg raising for how many seconds? This has to be done for nearly around 15 seconds, okay? Now, after that, again, make the individual to sit down in the native position with 45 degrees, that is for nearly around 30 seconds. So this will stimulate the vagus and it can revert the paroxysmal supraventricular tachycardia, right? This is another way by which you can activate the vagus. And the other way by which you can activate the vagus is, or decrease the heart rate is, facial contact with the cold water, right? Facial contact with the cold water. So facial contact with the cold water may cause transient bradycardia, and that will terminate the paroxysmal supraventricular tachycardia. And this particular reflex, it is called as diving reflex. right? So this particular reflex, it is called as the diving reflex. Okay. Now all these maneuvers, either you take carotid sinus massage or modified Valsalva maneuver, right, or the facial contact with the cold water, right, or coughing excessively, that is cough reflex. So this will abruptly terminate the arrhythmias in 20 to 50% of cases. Right, it will abruptly terminate the arrhythmias in 20 to 50% of cases, right? Now, if this vagal maneuvers fail, then you need to give injection adenosine, right? Then you need to give injection adenosine, and initially you need to give 6 milligrams of the adenosine, and this has to be given intravenous and as well as bolus. Right, so it has to be given through intravenous route and as well as bolus, and this should be followed by a saline flush. Now why is that you need to give a saline flush is because the half-life of the adenosine is very short. It is like 10 to 15 seconds. So once you give a saline flush, this adenosine which has been given through the peripheral line, immediately it will go to the heart and it will cause the AV nodal blockade. And with 6 milligrams, if there is no reversal, then you need to give 12 milligrams of the adenosine has to be given, right? And with 12 milligrams also, if the reversal come, then well and good. But always remember, whenever you are giving this adenosine, you have to check the background history of whether the patient is having any history of bronchospasm or bronchial asthma. And if the patient is having the history of bronchial asthma, then this supplementation of the adenosine is contraindicated, right? And with the 12 mg of adenosine, if there is no improvement, then you need to give a beta blocker, right? Beta blocker, okay? So that is cardioselective beta blocker like metoprolol can be given, and then non-dihydropyridine calcium channel blocker, okay? Now what is the example of this non-dihydropyridine calcium channel blocker is that includes the diltiazem, right? That includes diltiazem or verapamil should be given, right? Diltiazem or verapamil should be given. So this is the example of non-dihydropyridine calcium channel blocker, okay? So this is about like when the patient is having this PSVT, and always remember, if this particular patient with the PSVT, if the individual is hemodynamically unstable, right, if the individual is the hemodynamically unstable, right, then in such case you need to do a DC cardioversion, right? Then in such case you need to do a DC cardioversion, okay? So DC cardioversion will revert this particular the PSVT, paroxysmal supraventricular tachycardia, right? Then you take the other options. Now how will be the ECG in case of the other options? You take in ventricular tachycardia and ventricular fibrillation. These are the wide complex tachycardias. Let me show you these ECGs as well. So these are the examples of the wide complex tachycardias, whereas atrial flutter, it is a narrow complex tachycardia, right? A narrow complex tachycardia, and the P wave, it is of sawtoothed pattern, right? P wave, it is of sawtoothed pattern. So that is about the atrial flutter with the AV block, right? I'll be showing you that ECG as well. So let me show you first wide complex tachycardia and their respective treatment, and then I'll be discussing atrial flutter as well. So, right. So this is the ECG with wide complex tachycardia, right? And in any particular lead, if you take, okay, you take lead 2, all the QRS complexes, they are of same morphology. That is why it is called as monomorphic ventricular tachycardia, right? That is why it is called monomorphic ventricular tachycardia. Now, how is that? And if suppose in a given lead, if the QRS complexes, if they are of variable morphology, then that is considered as the polymorphic ventricular tachycardia. That is considered as polymorphic ventricular tachycardia, all right? Now, the point here is how do you treat? So these patients, the treatment is if the individual is hemodynamically stable, right? So if the patient is hemodynamically stable, then what is the drug of choice? The drug of choice will be the amiodarone. So amiodarone is considered as the drug of choice if the individual is hemodynamically stable. And if suppose, if the individual is hemodynamically unstable, then you need to do synchronized DC cardioversion, right? Synchronized DC cardioversion. And what should be the strength of this particular, the DC shock? That should be around 200 to 360 joules, right? 200 to 360 joules. So that should be the strength of the DC shock whenever you are giving DC shock in case of hemodynamically unstable VT, right? Now this was about the ECG related to the ventricular tachycardia. Then you take this ECG, this is also a wide complex tachycardia, and this is the ECG of ventricular fibrillation. Now how is that you will be able to identify the ventricular fibrillation is, in case of ventricular fibrillation, there is no identifiable QRS complexes, right? So there is no identifiable QRS complexes. That is what you will observe in case of the ventricular fibrillation. And these patients with ventricular fibrillation, they are always hemodynamically unstable, right? They are always hemodynamically unstable. So these patients, they have to be given the DC shock, right? And what should be the strength of the DC shock? It should be around 360 joules, okay? And here you are not able to identify the QRS complex. So here we don't give synchronized DC shock. Here what we give is asynchronized, right? So here we give asynchronized DC shock should be given. So that is about how you treat a patient with the ventricular fibrillation. Now let me show you the last option, that is atrial flutter. In case of the atrial flutter, you have this sawtoothed pattern of the P waves, right? The P waves, they are of sawtoothed pattern, right? And in between the R waves, right? In between the R waves, if the number of large boxes, if they are same, right? If the number of large boxes, if they are same, then we consider it as the atrial flutter with fixed AV block. Whereas here if you observe, the RR interval is variable, right? The RR interval, it is variable. So this we call it as the atrial flutter with variable AV block. Right? Atrial flutter with variable AV block. Okay, because RR interval is not same. So the block whichever is there, it is not fixed. It is like variable. Whereas you take in case of atrial flutter with fixed AV block. So this is the ECG of the atrial flutter with fixed AV block. So in atrial flutter with fixed AV block, the RR interval will be same, right? The RR interval will be same in atrial flutter with a fixed AV block, and the P wave, it is of sawtoothed pattern. Right? So the P wave, it is of sawtoothed pattern. Okay, so this is about, and this atrial flutter, it is narrow complex tachycardia, it is not wide complex tachycardia, right? So in the options which has been given to us, what is the answer there? It is PSVT, right? It is the PSVT is the only one which can get terminated by doing the carotid sinus massage, right? Now coming on to the next question, that is, which one of the following statement is correct regarding the opening snap in cardiac auscultation? It is a high-pitched diastolic sound. It is due to opening of stenosed aortic valve. It indicates the pulmonary arterial hypertension, and it precedes the aortic component of second heart sound, right? Now, so the correct statement here is, it's a high-pitched diastolic sound. It is heard during the diastole, right? And why does this opening snap occur? The opening snap, it is due to opening of stenosed mitral valve. Okay, it is due to opening of the stenosed mitral valve. Okay, And it is due to opening of the stenosed aortic valve is a wrong statement. Due to opening of the stenosed aortic valve, what is the sound that you will have is, that is ejection click, right? That is ejection click, right? Then it indicates pulmonary arterial hypertension is a wrong statement. In case of pulmonary arterial hypertension, what will be the important auscultatory finding is, they will have loud P2, right? They'll have loud P2, right? And it precedes the aortic component is a wrong statement. It will be heard after the aortic component, okay? So you take first heart sound, then second heart sound, and then again first heart sound. So in second heart sound, you have the A2 and as well as P2, right? Aortic component and as well as the pulmonary component, okay? Between S1 and S2, this phase is the systole. Between S2 and S1, this phase is the diastole, okay? So after A2, right, you will listen the opening snap, because the mitral valve is opened during the diastole. So it is heard after A2, not before A2, and it is a diastolic sound, right? Now let me just do a quick revision of this topic, important topic, that is mitral stenosis, okay? So mitral stenosis, if you take, what is the most common cause of the mitral stenosis is the rheumatic heart disease, and then many other causes are there, right? Mitral annular calcification will cause mitral stenosis. And first of all, when do you call mitral stenosis is, like, the normal mitral valve area is 4 to 6 centimeters square, and if the mitral valve area is reduced to less than 2 centimeters square, that is the point when we call it as the mitral stenosis, okay? And then we also have connective tissue disorders which will be causing mitral stenosis. That includes the systemic lupus erythematosus and as well as the rheumatoid arthritis. And we also have a storage disorder which will be causing mitral stenosis, and that particular storage disorder is the Hurler syndrome, right? So this particular storage disorder is the Hurler syndrome. So these are all the various etiologies that will be causing mitral stenosis. Then what will be the clinical features in patients with mitral stenosis is, in mild to moderate form of mitral stenosis, usually they are asymptomatic. It is only on exertion, right? It is only on exertion, these patients, they will have dyspnea, okay? In mild to moderate form of mitral stenosis, only on exertion you will have the development of dyspnea, right? Whereas in case of very severe form of mitral stenosis, where the valve area is like less than 1 centimeter square, in these patients, they will have dyspnea at rest. And that is because of the development of pulmonary edema. And not only that, because of the very severe mitral stenosis, there is left atrial dilatation causing atrial fibrillation, because of which these patients will also have the palpitations, right? These patients will also have the palpitations. And on examination, what is that you will have? On examination, the apical impulse, it is tapping type of the apical impulse, right? And in these patients with mitral stenosis, on auscultation, there are important auscultatory findings. The S1, it will be loud S1. But please remember, if it is calcified mitral stenosis, the type of S1 that you will have is the soft S1. Then in the S2, when you take a P2 component, the P2, it will be loud. If P2 is loud, what does it indicate? If the P2 is loud, it indicates the development of the pulmonary hypertension. Now, between S2 and S1, it is the diastole, okay? During the diastole or in the diastole, in patients with mitral stenosis, there are multiple additional sounds. That includes, number one, opening snap, which is a high-pitched sound. Then you have a mid-diastolic murmur, right, which is a low-pitched murmur, and it is heard best at the apex. Because it is a low-pitched, it is best heard with the bell of the stethoscope. And this murmur, it increases on the expiration, right? And after the mid-diastolic murmur, you will have presystolic accentuation. And this presystolic accentuation is due to forceful atrial contraction, okay? So that is about the auscultatory findings in patients with the mitral stenosis, okay? Right, then, right. So coming back to the question, so in mitral stenosis, the opening snap, right, it is a high-pitched sound. Whereas the treatment and as well as the workup in mitral stenosis, I will be discussing that in the next question. Whereas you take opening of the stenotic aortic valve, right, aortic stenosis I'll be discussing in the other question in detail, but please remember the normal aortic valve area, it is around 3 to 4 centimeters square. And when the valve area is reduced to less than 2 centimeters square, that is the point when we call it as the aortic stenosis. Okay, and opening of the aortic stenosis, aortic stenotic valve will cause ejection click. Will cause the ejection click. Okay, then coming to the pulmonary arterial hypertension, as just now I have said you will have a loud P2, and it precedes aortic component is a wrong statement. So this is about the question related to the mitral stenosis. And let me just discuss few points about this second heart sound, which is very, very important for the discussion. So if you take the second heart sound, it is heard during the protodiastole, right, or during the isovolumetric relaxation phase, and it has two components, A2 and as well as P2, right? And you take the gap between A2 and P2, it is that is nothing but split. Okay, so the split is present only during inspiration, right? The split is present only during inspiration, whereas the split, it disappears during expiration. Okay, the split, it disappears during the expiration. The split will be there only during inspiration. All right, then the next important point here is the gap between A2 and P2, it increases in certain conditions. Now, what are the conditions where the gap between A2 and P2 increases? So the gap between A2 and P2 increases due to early A2, right, or due to delayed P2. So due to early A2 or delayed P2, you will have a wide split S2, right? Now you take the early A2. Early A2, you come across this in patients with the mitral regurgitation and ventricular septal defect. What are the conditions where you will have delayed P2 causing wide split of the S2? You will have that in patients with the pulmonary stenosis. You will have that in patients with the pulmonary embolism. You will have that in patients with the pulmonary hypertension, right? And you will have that in patients with the right bundle branch block. Okay, you will have that in patients with LV ectopic beats. You will have that in patients with LV paced beats. Okay, so in all these conditions, you will have a delayed P2. In all these conditions, you will have delayed P2. Okay, so this is about regarding the S2. And there is one condition, or there are some conditions where you will have a single S2. Like for example, you take in patients with the systemic hypertension. In patients with systemic hypertension, you will listen S2, right? That is only A2 is heard. So you will have loud A2, right? You will have loud A2. That is in systemic hypertension. Whereas you take in case of the pulmonary hypertension. In pulmonary hypertension, you will listen only single sound, and that is loud P2, right? That is loud P2. Okay, so single sound is heard in systemic hypertension and as well as the pulmonary hypertension. Okay, so this is about the discussion related to the second heart sound. Then coming on to the next important clinical scenario, we have a 35-year-old laborer, right? He consulted the local medical practitioner for recurrent attacks of chest pain. His elder brother had similar complaints and died at the age of 40 years. The laborer was advised to take sublingual nitrate at the time of chest pain. But after taking the nitroglycerin, the chest pain increased in intensity. Which of the following is the most likely diagnosis? The options are hypertrophic obstructive cardiomyopathy, chronic type A dissection of the aorta, degenerative mitral regurgitation, subacute bacterial endocarditis involving the aortic valve. Okay, so the chest pain which is increasing after taking sublingual nitroglycerin, the very important diagnosis is the hypertrophic obstructive cardiomyopathy. Now, in order to call it as the hypertrophic obstructive cardiomyopathy, please remember, there should be increase in the thickness of the ventricular wall. And how much should be increase in the thickness of the ventricular wall? The increase in the thickness of the ventricular wall, it should be more than 1.5 centimeters. Okay, and if it is particularly at the septum, we call it as septal hypertrophy. I'll be discussing the hypertrophic obstructive cardiomyopathy subsequently in the other questions in detail, but let me tell you, by giving sublingual nitrate, why the chest pain increases in patients with the hypertrophic obstructive cardiomyopathy, right? So whenever you are giving sublingual nitrate will decrease the preload. Okay, sublingual nitrate, it will decrease the preload. All right, now sublingual nitrate, when it is decreasing the preload, what will happen to the right ventricular volume? Decreases. Subsequently, what will happen to the left ventricular volume? Even the left ventricular volume also decreases, right? Even left ventricular volume also decreases. Now, as the left ventricular volume decreases, what will happen to the distance between the septum and as well as the anterior mitral leaflet? There will be narrowing of, because you have what is called as a terminology called SAM, that is systolic anterior motion of the anterior mitral leaflet. During the ventricular contraction, the anterior mitral leaflet, it comes near to the hypertrophied septum. Okay, so whenever the preload is reduced, the LV volume is reduced. When LV volume is reduced, the hypertrophied septum, it comes very much near to the anterior mitral leaflet. So thereby, what will happen to the cardiac output? The cardiac output, it is decreased. The cardiac output is decreased. Now, once the cardiac output is decreased, what will happen to the coronary perfusion? Right? What will happen to the coronary perfusion? The coronary perfusion also decreases. Right? The coronary perfusion also decreases. Right? Now, once the coronary perfusion decreases, the chest pain, it increases. Okay? Because in hypertrophic obstructive cardiomyopathy, it is your hypertrophied septum. This hypertrophied septum, right, the demand is more, and if the supply is less, that will result in the increased angina. That is the reason why in patients with the hypertrophic obstructive cardiomyopathy, the nitrates should not be given. And not only nitrates, any drug, right, not only nitrates, any drug which is decreasing the LV volume, like for example, you take furosemide. Okay, so even this furosemide will decrease the LV volume. Nitrates will decrease the LV volume. Thereby the obstruction increases, coronary perfusion decreases, and that will precipitate the angina. Okay, right. Then next, the other, so your furosemide is contraindicated. Nitrates, they are contraindicated, right? And the next two other drugs which will increase the cardiac contractility is digoxin and as well as the sympathomimetic amines. Right, sympathomimetic amines. So digoxin and as well as sympathomimetic amines, they increase the cardiac contractility. Once they increase the cardiac contractility, the septum, right, it will come very near to the anterior mitral leaflet. So the cardiac output decreases, coronary perfusion decreases, demand is more, supply will be less, and that will precipitate the angina. That will precipitate the angina. Okay, so very important point, please remember here, the drugs which are contraindicated in HOCM, nitrates, diuretics, digoxin and sympathomimetic amines. So these are contraindicated in patients with the hypertrophic obstructive cardiomyopathy, right? So the answer here is the HOCM. Okay, in case of type A dissection, right, it is nowhere related to the nitrates increasing the pain, right? Usually in case of, I'll be discussing this aortic dissection subsequently, it will be having tearing type of pain. Now, mitral regurgitation, they don't have any chest pain at all. And subacute bacterial endocarditis, usually these patients will have high grade fever, they will develop the myocardial infarction only when the embolus, right, that is the vegetation which is fragile, which is friable, if it is entering into the coronary circulation and causing impairment of the myocardial perfusion, then the individual will develop chest pain. Otherwise, in patients with subacute bacterial endocarditis, you don't have chest pain at all. Now, let me discuss few points about this mitral regurgitation. So, right, so if you take this mitral regurgitation, we have two important etiologies causing MR. One is acute MR and the other one is the chronic MR. What are the causes for acute MR? Acute MR is the one which occurs abruptly. And this acute MR, you see that in patients with the anterior wall MI and as well as the inferior wall MI. Why? Because in anterior wall MI and as well as inferior wall MI, there can be rupture of the papillary muscle. Once there is rupture of the papillary muscle, that will cause the mitral regurgitation, and that too it is acute in onset. Okay. And next is the valve perforation. Right, next important is the valve perforation in case of the infective endocarditis, right? Then in patients with the hypertrophic obstructive cardiomyopathy, then in cases of ruptured caudate tendinae, right, in cases of ruptured caudate tendinae. So these are all the causes for acute mitral regurgitation. And these patients with acute mitral regurgitation, they develop pulmonary edema. And these patients, they will present with sudden onset dyspnea, right? They will be presenting with sudden onset dyspnea. Okay. And on examination in patients with the mitral regurgitation, they will have a short systolic murmur. And this short systolic murmur will be, it is the early systolic murmur. Right, this short systolic murmur, it will be the early systolic murmur. That is what you will have in case of acute mitral regurgitation. And these patients, they require immediate surgery. Right, these patients, they will be requiring immediate surgery. That is in case of acute MR. Whereas you take in case of the chronic MR. What are all the various etiologies that will be causing chronic MR is like the mitral valve prolapse. It may not be due to the anterior wall MI or posterior wall MI. In connective tissue disorders, there can be mitral valve prolapse like Ehlers-Danlos syndrome and Marfan syndrome, right? Rheumatic fever, it can cause the chronic MR, right? And the other important conditions are the cardiomyopathies like dilated cardiomyopathy or even the restrictive cardiomyopathy. So these are all the causes for chronic MR. So in case of the chronic MR, please remember, they will have the important clinical manifestation as the palpitations, because in patients with chronic MR, there will be left ventricular dilatation causing palpitations due to premature ventricular contractures or the ventricular arrhythmias. And once there is left ventricular failure due to MR, then these patients will have dyspnea due to development of the pulmonary edema, right? And in patients with MR, how will be the apical impulse? The apical impulse, it will be hyperdynamic type of apical impulse, that is what you will have in patients with the mitral regurgitation, right? And what is a murmur? And on auscultation in patients with MR, the S1 will be soft because the mitral valve is not closing. And the next important point is the murmur will be the pansystolic murmur, right? The murmur that you will have is the pansystolic murmur. That is what you will have in patients with the chronic mitral regurgitation, right? And how is that you will evaluate this chronic MR? You will evaluate this chronic MR with the help of the 2D echo, right? And when you do a chest X-ray, the chest X-ray will show you that there is left ventricular dilatation. There is left ventricular dilatation. Then how is that you will treat these patients with chronic MR, right? If there is exertional dyspnea, then in such case, you need to give diuretics, you need to give beta blockers, and you need to give ACE inhibitors or angiotensin receptor blockers can be given. But if the MR is very severe, that is the point when these patients will be requiring mitral valve replacement. So that is about the discussion related to mitral regurgitation, right? Coming on to the next question. A patient with atrial fibrillation on regular treatment, he presents with the photosensitivity, skin discoloration, and peripheral neuropathy. Which drug may be implicated? Digoxin, disopyramide, amiodarone, and as well as the bisoprolol. Okay. So here the answer is the amiodarone. Okay. So amiodarone, it has a wide range of the side effects, And this particular wide range of side effects, it includes the photosensitivity, right? And it is also associated with skin discoloration. And what is this particular skin discoloration is? This skin discoloration includes bluish gray discoloration, right? It is associated with bluish gray discoloration. And another important adverse effect of the amiodarone is it is also associated with the peripheral neuropathy. Now, see, the atrial fibrillation as such, it's a very, very important topic. So, in case of atrial fibrillation, what will be the common clinical presentation is palpitations, right? And how is that you will be able to identify the atrial fibrillation? You will be able to identify the atrial fibrillation with the help of the ECG, right? With the help of the ECG. What does the ECG show? The ECG, it will show you that there is loss of, absent P wave. Right? So in the place of P wave, what is that you will have is the presence of the fibrillatory waves. Right? Presence of the fibrillatory waves. That is what you will have. And how will be the rhythm? It is irregular rhythm. So they will have a variable RR interval. Right? So they will have a variable RR interval. So that is what you will observe in the ECG of a patient with the atrial fibrillation. And this is how you will identify the atrial fibrillation, right? Then followed by that, if you take the etiology of the atrial fibrillation, the most common cause of the atrial fibrillation, it will be hypertension. But there are many other causes which are causing the atrial fibrillation. So the mnemonic is the atrial fib is a mnemonic. A stands for the alcohol abuse, right? A stands for the alcohol abuse, and as well as excess caffeine, right? T stands for thyroid disorder, okay? And what is this particular thyroid disease? That includes hyperthyroidism, that is thyrotoxicosis. R stands for the rheumatic heart disease. I stands for the ischemic heart disease. A stands for the atrial myxoma, and as well as the atrial septal defect, right? L stands for lung pathology. Now, what is that lung pathology is? That includes the pulmonary embolism and as well as the emphysema, right? As well as the emphysema. And PH stands for pheochromocytoma, right? PH stands for pheochromocytoma, okay? And I is idiopathic, we don't know what exactly is the cause. B stands for blood pressure, that is hypertension, okay? So these are all the causes for the atrial fibrillation. Then how do you treat these patients with the atrial fibrillation? So if you see the treatment of the atrial fibrillation, so we have the three important group of drugs, right? Number one, we have the drugs which will cause the rate control, right? And these drugs include beta blockers, right? And these drugs include non-dihydropyridine calcium channel blockers, right? Non-dihydropyridine calcium channel blockers, okay? And next is rhythm control. Rhythm control, it is done by the anti-arrhythmic drugs, and these anti-arrhythmic drugs include the amiodarone and as well as the ibutylide, right? Amiodarone and as well as the ibutylide. Then these patients will be requiring anticoagulants or the antiplatelets. Now, whether to give anticoagulants or antiplatelets, you need to calculate CHART2 DS2 VAS scoring system. I'll tell you what is this. But among these three group of drugs in patients with atrial fibrillation, which is a very important drug, rate control is very, very important, right? Rate control is very, very important then compared to that of rhythm control or anticoagulants or antiplatelets, okay? Rate control is one what you need to achieve first. and that can be achieved by giving the beta blocker or non-dihydropyridine calcium channel blocker. And in those individuals like bronchial asthma, or in patients with COPD, or in patients with respiratory disorder where you are not able to give the beta blockers, in them you need to give non-dihydropyridine calcium channel blockers. Okay. Then coming to the rhythm control. Rhythm control, it is achieved by the class 3 antiarrhythmic drug, that is amiodarone or ibutalate can be given. Now, whether to give anticoagulant or antiplatelet, that is calculated by your CHA2DS2 VAS scoring system. Now, what is this CHA2DS2 VAS scoring system? So, C stands for the congestive heart failure. If it is there, give a score of 1. And H stands for the hypertension, right? So you need to give a score of 1 if there is hypertension. A stands for age of the individual more than or equal to 75 years. If it is there, give a score of 2 points. D stands for the presence of or development of diabetes mellitus. If it is there, give a score of 1. S stands for, right, the development of stroke. Okay, CHA2DS2, right? And that is stroke. So if there is presence of stroke, give a score of 2. And V stands for the vascular disease. So if there is vascular disease, then you need to give a score of 1 point. Then A stands for age of the individual. So age of the individual, if it is more than 65 years, then give a score of 1 point. And the word SC, okay, right? VAS scoring system, SC. So that is the gender. So if the sex of the individual, if the gender of the individual, if it is a female, then you need to give a score of 1. Okay. So if CHA2DS2 VAS scoring system, right, if it is 0, we give antiplatelets or no drug. If CHA2DS2 VAS scoring system is 1, then you need to give the antiplatelets or the anticoagulants, right? And if the CHA2DS2 scoring system is more than or equal to 2, then definitely you need to give anticoagulants, right? Definitely you need to give the anticoagulants. Okay. So this is about your CHA2DS2 VAS scoring system, right? And this is the treatment of the atrial fibrillation, rate control, rhythm control, and as well as the antiplatelets or the anticoagulants should be given. So this completes the discussion of your atrial fibrillation and as well as its treatment. So coming on to the next question, which of the following produce loud S1 on the cardiac auscultation? Anemia, pregnancy, thyrotoxicosis, mitral regurgitation. Select the correct answer using the code given below. So among the options here, right, anemia, pregnancy, thyrotoxicosis is the one which will be causing loud S1. Whereas in case of mitral regurgitation, they will have soft S1, because in mitral regurgitation, mitral valve is not closing completely. That is the reason why they'll have soft S1. So if you see the discussion related to the S1, if you take the frequency of the S1, it is the one with medium to high frequency sound. Okay. Then if you take the duration of the first start sound, it is around 0.14 seconds. And if you take the interval between M1 and T1, it is around 20 to 30 milliseconds. Right? It is around 20 to 30 milliseconds. So you don't have a split now. Right? If the duration is just only 20 to 30, the split is absent, right? And the next important is, what are the conditions where you will have loud S1 and what are the conditions where you will have the soft S1? Okay. The conditions where you will have the loud S1, you get that in all hyperkinetic states. What are the hyperkinetic states? The hyperkinetic states, they include the following, that is anemia, thyrotoxicosis, beriberi, AV fistula, pregnancy, then Paget's disease of bone and fever. So these are all hyperkinetic states where you will have loud S1, right? And next is the conditions where there is prolonged AV flow. So what are the conditions where you will have the prolonged AV flow? Prolonged AV flow, it is observed in patients with mitral stenosis and as well as the tricuspid stenosis. right? These are the conditions where you'll have prolonged AV flow. Then in patients with short PR interval, right? Short PR interval. So where the PR interval is less than 120 milliseconds, and you will have that in patients with the WPW syndrome. Then what are the conditions where you'll have the soft S1? You will have soft S1 wherever there is poor conduction of the sound, right? Wherever you have poor conduction of the sound to the surface of the chest, like obesity, emphysema, pericardial effusion, left-sided pleural effusion. So in these conditions, there is poor transmission of the sound to the surface of the chest. Thereby you will have soft S1, right? Then in conditions where there is decrease in the LV contractility, you will have in cardiomyopathy, mitral regurgitation, acute myocardial infarction, and myxedema, which is nothing but hypothyroidism. Okay, so these are all the conditions like mitral regurgitation, acute MI, cardiomyopathy, and hypothyroidism. You will have decrease in the LV contractility. Then in conditions like prolonged PR interval, right? Prolonged PR interval where the PR interval is more than 200 milliseconds. So in prolonged PR interval, you'll have soft S1. And then in cases of calcified mitral stenosis and tricuspid stenosis, you will have soft S1. So these are all the conditions where you will have the abnormalities related to the first heart sound. And there is one particular condition where you will have reversible S1, right? Now, what is that condition where you will have reversible S1? Reversible S1 means where you will have T1 followed by that M1. You will have that in patients with left bundle branch block. In left bundle branch block, you will listen first T1 and followed by that you will listen M1. Okay. So this is about the conditions where you will have reversible S1.